Hello, I'm Trish Del Grasso. I am a senior nurse consultant with Surgical Directions. I've been an operating room nurse for 35 years, and I have progressed from a scrub and circulator through to a AVP of surgical services throughout that time period. Today, we will be discussing flip rooms. It is every surgeon's dream to have a flip room because they measure their efficiency by that. It is also a double-edged sword for every OR director trying to manage physician expectations and satisfaction with OR efficiency and productivity. So a flip room is a surgeon has the ability to book in two rooms on the same day concurrently, where they'll start in room one, and then when the critical component of the case is completed, they can move to room two with a totally different team of circulators, scrub techs, and anesthesia providers. This helps them put more cases on the schedule in a single day versus having to follow themselves. It cuts out the turnaround time between the two cases, which can range anywhere from 30 to 45 minutes, depending upon the size of the case. This is a physician satisfier because their time can be managed better between their office and their surgical days. So where the flip room is efficient for a physician, so they have less downtime, there are certain conditions that have to be met for it to be efficient for the operating room. If the cases are too long, it produces inefficiencies in the OR through non-productive time for the staff that's waiting for that case to finish to move the next case in the room. Most OR rooms have a cost of between $50 and $85 per minute. When flip rooms are not used correctly to maximize cases and efficiency, you have staff that are assigned to that room that will have too much downtime in between cases, decreasing productivity and also impacting the ability to have a revenue generating case in that room. Also, it impacts the anesthesia provider who also will not be hitting those productivity marks for that day because of the downtime in between the flip room cases. In a small community hospital in Illinois, we were working with a client who there was very little guardrails on the flipping policy. If you asked for a flip, you got a flip room. And unfortunately, there was no one monitoring the parameters of that. It was based solely on physician satisfaction. So in two rooms where you should have been able to have anywhere from 4 to 6 cases per room, they were only having 3 cases per room and maybe 3 in one room, 2 in the other, which then left that 8-hour day half empty in each room. So the productivity and the utilization for those 2 rooms combined was only 50%. When we adjusted the expectations for a flip room and where those parameters were, they were able to get in 7 to 8 cases in those 2 rooms per day based on the length of the cases, the efficiency of the surgeon, as well as the support staff. So this particular hospital, when we engaged with them, they were not aware that the way they were allocating flip rooms to their surgeons was impacting their overall efficiency, throughput for their patients, and their revenue generating potential. We were able to work with them to identify some parameters around flip rooms, had discussions with their surgeons through the block redesign process, and we were able to allocate flip rooms to appropriate surgeons doing the appropriate cases with the appropriate staff. So some complications that can arise when you're trying to engage in a block redesign is physicians who have been accustomed to having a flip room that no longer qualify based on standardized guidelines to be allocated a flip room. Those are the major discussions that have to take place one-to-one in a peer-to-peer model. We also find that there may be more than one physician or more than the currently allocated physicians who qualify for block allocations with a flip room. So finding space for those cases and those physicians can be challenging just based on how many operating rooms you have, how many physicians have a block schedule, and how we can influence that allocation of a second room for those physicians that really fit those qualifications. So when we're looking to allocate flip rooms to a particular surgeon, there is a lot of data that goes into that. The first is, what is the time frame of those cases? Those cases should be between 60 and 90 minutes each. That allows for the opposite room to have the room cleaned, the equipment brought in, and the instrumentation and the room set up to begin at the same time that the surgeon is operating. So again, the first criteria is the length of the case. It should not be any longer than 90 minutes. That decreases the productivity of the operating room when that happens. The second criteria is the number of cases, and that's based on the type of cases. So if you have a flipped room, we would like the productivity for those rooms to be at 65% productive with the adjusted utilization. For that to happen, that physician should have anywhere between 6 and 8 cases per day, depending upon the size. When you get into cases where it's 3 to 4 hours, that really decreases the productivity of both of those rooms, and they can't meet that adjusted utilization of 65% for those two rooms combined. We would like to have like cases. It does increase the efficiency back to back. Another important consideration when allocating flip rooms is to look at the operating room as a whole. Do we have enough of the equipment to manage flipping those rooms back and forth? Do we have enough trays for those specific procedures? What is the turnaround of those trays to be reprocessed in between? So resource allocation is a very important consideration, which again is why you would want to include your OR directors and managers, your surgeon leads, as well as your anesthesia leads. So an important component of block utilization, block allocation, and flip room allocation is to be data-driven. Physicians respond to data, which we at Surgical Directions have a proprietary software called Merlin. Merlin collects the data from your medical record and it puts it in a format that is understandable when making decisions on block allocations. It produces a surgeon-specific scorecard, everything from their block utilization, how much they're operating outside of their block, how much block they release on a regular basis, the timing of it, does it automatically release or are the physicians releasing it timely? It speaks of how many flips they have in a day. You can drill down to how long the turnaround time is between those cases. This is invaluable to leadership of the OR, that there is an option to present the data in a concise format to the surgeons. We have been fortunate to help organizations see results using our Merlin software in their block redesign process to decrease white space. When I say white space, that is times of day in each room that do not have a case in it, which again decreases efficiency of the OR. We have been able to decrease that white space, resulting in predictability for all team members. The surgeons understand or have an idea of when they're going to finish. Staff have a predictable end to their day. Anesthesia has better ability to plan for their day for later cases, for days ending earlier, where they can maybe share resources with other departments outside of the OR. To quantify this for a surgical director, we would be able to look at overtime expenses and increase case volume with the ability to use a flip room. So a surgeon who would normally only be able to do 4 cases in one room per day without incurring overtime expenses, we were able to do up to 7 cases per day for that surgeon without going into that overtime. So for most organizations, we can decrease that incidental overtime as well as increasing cases by about 25%. I think the most important consideration is a team approach. Without making decisions in silos, the OR director, the chairman of your surgical executive committee, as well as your anesthesia chief to work together to come to solutions that work for the entire organization, being mindful of resource allocation and resource utilization.